Good morning, good afternoon. Welcome everybody to today's presentation on situational awareness of fire, a SANER approach. Today we're welcoming Dave Pike to join us from Texas Health Services Authorities, the ONC, and Audacious Inquiry. At this stage, I just want to do just a couple of quick housekeeping notices here, please. Firstly, just if you have any tech issues, please just drop your comments in the chat field. We'll try and deal with them as they come in. If you have any questions for the speakers, for the speaker Dave, please once again drop them in the chat field, and we'll get to them as we have the opportunity at the end. The session is being recorded and closed captioning is available, so you can adjust your settings in the box below. And if you want to have this session recorded on your attendance certificate, please make sure you check in on the check-in survey. So at this stage, I normally would give a quick bio of Dave, but I think he's got that covered in his own slides. So he's just said make something up. So it gives me a great pleasure to welcome Dave, the man who invented the peanut butter jam sandwich, and actually holds the world record on doing a marathon in a wetsuit, to speak today about fire. So over to you, Dave.
Thank you, Fergus. Here, let me bring up my slides. And they look something like that. Okay, welcome. And now to give my actual introduction, who the hell am I anyway? My name is Dave Pike. I'm a subject matter expert and senior project manager at a company called Audacious Inquiry. Just to give a little bit of my pedigree, I've been involved with fire since 2012, so 10 years now, and I even have my 10-year mug. I was part of the original QA team for STU1. Currently, I'm a member of the HL7 International Technical Steering Committee. I'm co-chair of the HL7 Community-Based Care and Privacy Work Group. I'm up to 7 fire IGs, and I've also trained people in how to create them. And of course, my proudest accomplishment, I have 2 wonderful daughters, 9 and 12 years old. I've been a part of the SANER project since its inception, and so have had a chance to really do some in-depth understanding of it. So hopefully there are people who have questions and who let Elliot Silver in the room. Oh, wait, no, sorry. So let's get started. While I work up, there we go. So basic objectives of the sessions will give you an overview of the FHIR IG content, describe how it's been used to support situational awareness for emergencies like COVID, and that's for hospital capacity and supporting information. Obviously, we're not going to get into locational data for sites and things like that, but we can give the information needed to help healthcare actors and their operations supported by the IG get the information they need to make useful decisions. We're going to show how the measure report resource can be submitted and retrieved from a SANER server using simplified measure reporting, both in FHIR and in CSV. And right now we'll show you how that information is being used and will be used in a pilot that we're starting off in Texas. We're also looking at doing it in 3 other locations around the world. So a little bit of information. SANER, situational awareness for novel epidemic response, started, well, a year ago, February, because we were working with the New York area, we were working with some of the other areas as they tried to understand what was going on and route patients with COVID to a place where a bed and a ventilator was available. This was all being done by fax. So what would happen is the local healthcare association, or Public Health Association, there we go, would be faxed the questionnaire that you see on the right, which basically says how many people do you have, how many beds of any type, how many are inpatient, all of this would be all faxed to one person. That person would then spend the better part of a day correlating it, and by that time the data was so stale it was almost useless. This was a problem, obviously, because when you have ambulances running around the city, trying to bring people to bed to get them intubated in time you can't wait for somebody to say, well, wait a minute, let me look through this pile of paper. And literally it was a pile, sometimes up to 4 feet high, of reports that needed to be done on a daily basis. And in fact, many of the hospitals were taking 2 people full time just to fill in this report and keep it up to date and fax it in once an hour. This was insanity. And so with FHIR APIs, we decided we can make this better. We may not be able to fix it for now because, well, we need to figure out how, but we'll be ready for next time. So what is situational awareness? Well, the most basic level is the essential elements of information in terms of art in emergency response. Oh, isn't that a lovely statement? Really, it's broadly defined for transportation, air, water, roads, infrastructure, so power, water, fuel, communications, affected populations, shelter, command and control, and that little one at the bottom, healthcare. And really what we found is for most of the other ones, there are military guides, there are really major things going on, but in healthcare, there's almost no useful coordination to understand what's going on inside a hospital when emergencies happen. In some areas, they may be able to search up patients and say, hey, where is Jane Smith at this time? But you can't say, hey, I've got a patient that needs this treatment. Where can I bring them? And get that information in a useful way. So getting the operational status and the location of the hospitals that have capacity is mind-blowingly complicated, but shouldn't be. So we went forward to see if we can bring this to FHIR. Okay, so what it is we needed to figure out the measures. So capacity utilizations, what do you have? What are you using? So break it down. How many beds do you have? How many are occupied? How many are occupied of each type? Do you have an ICU bed? Do you have a pediatric ICU bed? What do you have? Do you have overflow capacity in the parking lot? Where can we bring somebody? Event counting. How many times has this happened today? How many people have been admitted into the system? How many people has this happened? What is your 15-day trends? What is your 2-day trend? Queue lengths. How many are waiting? How long are they waiting? And of course, what status are they in? Right? It is no good to say you've got 35 COVID patients, but if you don't know how many in ICU, how many are in critical, and how many are just sitting there coughing on each other, that's not going to work. So when we're doing this, when we're looking at this from a data point of view, this is similar to all the things you measure today, right? When we're looking at normal and surge capacity, that's the same as CPU and memory. So we can say, what is your normal CPU use? What is your normal, what have you allowed for burst capability? So, are you holding around, 5%, 20% CPU on an average load, but you're bursting up to 80%? Same for a hospital, right? How many beds do you have? What is your normal capacity? If it was surged, how many could you handle? And of course, how many is up in use currently, and what is available? What is your maximum amount? Same as you say for memory, right? Right now it's in use 10%. However, we could blow it out to 80% if we needed to. Event counting, how many are infected, how many recovered, how many have died from it, how many have been tested. This is all the same as you do with CPU everywhere, with PCs everywhere. Your error counts, process errors, communication errors, content errors, what bugs you're tracking, because there are no bugs. None of our software has bugs. Queue length for connection pools, sockets, locks, service time, so average response time, and of course, general status, red, yellow, green on anything. And these are not different, right? These are measures that we do every day, and getting them transferred from an EHR system is just looking at a new source. So if you're using things like Elasticsearch, if you're using that to monitor your system, you can use FHIR the same way by simply querying it periodically. Obviously, maybe real time might be a little bit much, but once an hour saying, okay, how many people are in your beds now? How many people have you admitted? How many tests have you done? That kind of information can be used and can be used effectively if it's available in real time or near real time. If we have to wait a day to find out, how many beds you have available, by the time you submit that number, it's wrong. and we can't make decisions on wrong information, or we can't make good decisions. Oops. All right, so communicating the measurements. Let's look at this. So the basic information is the EEIs, right? And we went above them. For hospitals, it's important that we collect the information as we need it from the various provider informations, from multiple information systems. And that's the big thing, is that in almost no system can we do this from one EHR. We need to go much wider and bring it right across, collect it, aggregate that data from those systems into a combined report, and pass that up to emergency response agencies through public health, up to the public health agency, up to the regional public health, up to the national public health, so that people can see what's going on. And this is not, I should say, this is not just for illnesses. We deal with emergencies of weather, right? Hurricanes or tornadoes that can bring the public health response to its knees because they have no idea who's got power, who's flooded, who's got and then we get into, okay, we know that they're up, but how many beds do they have? Can we get this information out? And then can we start aggregating it up on a wide scale? If you look at, look at COVID and the way it impacted all over the world, right? We heard stories, horror stories out of Spain, out of Italy, out of Greece, saying, people are racing around. There are no beds anywhere around. Nobody knows what's going on. When in reality, that could have been shared by getting the information into the right hands, aggregating it up so decisions can be made to start moving resources around. So if you have extra beds, you can start moving patients there. If for some obscure reason you have extra PPE, you can move that around. If you have extra staff, so you have on call for 5 extra care providers, whether it's nurses or doctors, you can say, wait a minute, you have an excess at the moment, let's move them over here so that people can make these decisions. So we designed this system around base actors. Now, for those of you who have worked with IHE profiles, you will recognize a lot of this concepts of the actor and transaction. If you mostly work in FHIR, not so much, because that kind of thing tends to be reserved for point to point. So we defined a number of actors. So it starts off with the measure definition source. So that's often the public health agency, or if we're measuring other things, can be other groups. But the public health agency says, these are the kind of things that we need to know. We need to know them at this level. So they will create a FHIR measure, and we'll get into what those look like in a second. They will create that and either make it available or push it down to the measure consumers. And from their name, they consume the measures so that they can bring them in and start activating what they need to pull that information together. The measure source is the person who's reporting it. So they're the ones who take the measure definition, they aggregate the information as necessary, so they create the various components of it, and pull together the measure report, also a FHIR resource. From there, they can pass it up to all the way up to the measure intermediary, who can aggregate it all the way up to public health. Now, along the way, we have the measure computer, and they're the ones who are going to take the measure source and actually sit down and calculate what the resources are, because a lot of these things are based around the concept of, do you have a 15-day supply? Well, that can only be determined by calculating what that means. How many do we use under normal situation? How many do we keep in reserve? That kind of thing. And of course, the data source itself, which is the EHR for one, but is also possibly the workforce management system, the bed management system. There can be an inventory system for PPE. All of these systems may need to be connected to get the information in an automated way. Again, many hospitals have 1, 2, sometimes 3 people whose whole job it is to fill in these reports on a daily basis, sometimes many times a day. We're trying to automate this, get it out of the hands of somebody who can then do real useful work, not sit there counting how many masks are sitting on a shelf. That being said, many times it comes down to how many masks are sitting on the shelf, because we only keep a track of it in boxes, and we need to know it in, day use. Okay, so, and like I said, not all the sources are created equally. Okay, we have a whole bunch of them that we need to worry about. The asset management, because that's how you may be tracking your intubations, that your ventilators, your bed management system. That's fairly obvious, but it needs to know how many different types of beds. Some of them only know that it's in this location, and if it's in this location, it's an ICU bed. But in times of emergency, an ICU bed can be almost anywhere. You can hook up the right systems, right? Whether you can intubate somebody, you have enough, nursing staff to make any bed into from an acute care bed into ICU. Workforce management systems, how many nurses, how many doctors, how many interns, how many care providers and support staff are there to make it so those beds can function. Because just because you have a bed doesn't mean you have the workforce necessary to support it. Labor and delivery, inventory, of course, if you're looking for PPE, it's usually only in the inventory source. Sometimes it's on Carol's clipboard, especially if you're in a smaller regional hospital. The inventory system is literally somebody's clipboard. That needs to be translated and sent into the system. The central monitoring system to keep track of everything, laboratories to keep track of tests, and on and on and on. And of course, command and control, which hopefully is able to put this all together. Okay, so the important thing to realize is that we're not running in 100% FHIR world yet. I would really love it, because having been in FHIR this long, it's really important to have FHIR be there, because unlike many of the previous systems, it's being designed around interoperability. It's being designed around use cases. If you look at V2, which was created 30 years ago, it was based around event mapping. So it works because we've all developed our systems around event mapping. If you look at V3, that was created around a model, and it's really useful, but it's extremely hard to implement, which is why in many cases V3 just never took off. So FHIR, if you've been through any of the openings, was created through interoperability, and that becomes true for all sources of data, but it's not everywhere. So we had to do it with CSV. Many of the systems are, able to export or import common separated values systems. We can take that because measures are pretty simple, right? We just want to know things like how many of X and how many of Y, or when is it started. So we created a way to do it. And the SANER server that we've developed and is built in line with the FHIR IG is there to actually bring this information. We created actors specifically allowed to bring in CSV values because we're not going to assume that everybody is FHIR. So if you can push a CSV, you're still working within the system. The system will translate it into FHIR, put it as part of the bundle, and send it up. The bundle itself, of course, is the measure report, which is, an aggregation unit. So in FHIR, sorry about that, I live on a main street. In FHIR, the measure definition is done through the measure report, or the measure resource. There we go. And it's very simple, right? You can just simply say, I need to know how many of this exists, or what questions are. The measure report is literally just the response to that. And while it was built around the US clinical quality measures, we realized it could be used for anything. And when we started this, we started off saying, well, we'll just echo the questionnaires that have been developed, and questionnaire response should do us. And then we realized this is dumb, because we need to make it so that supplemental information. A lot of times when we're doing this, we need to have, as part of the bundle, all of the patients, or all of the tests, or all of the somethings to go with it. So we created profiles on Measure and Measure Report to do this, and in a lot of ways we broke the way it was done. Hopefully people are still awake. Okay, so how does the over work? Basically, we start off with connections to the EHR, usually either directly to the server if we can, or we'll set it up with an application. So we have a Smart on FHIR app, which we're working through, getting through it. We've developed it with a number of other agencies. Other companies have been involved in this. This isn't just Audacious Inquiry. This has been fairly large. We've actually been working with Epic and SANER to get the information right, to have them support it directly, because everybody is realizing that this kind of information is absolutely necessary. So the Smart on FHIR app is the one that usually goes in, authorizes itself using Smart, and then we'll query the data. So what do you have that's available in FHIR? And obviously, if it's connected to a lab system, we'll have the lab results. It should have patient admissions. It may not have the beds, which means we need to get that from somewhere else. But it queries it, it creates a base measure report from the EHR data and sends it off to the head server. The SANER itself can take that. It will collect data from the other sources. So it will receive the data through FHIR if it can, through CSV if it must, and it's even possible that it's designed around customization, so it's possible to have a SANER server receive it in any format, but translation becomes the question. And then aggregates that all together, pulls it so you have all the measures mapped together, and then you report up to the local command and control in the hospital system, and also to regional state public health or provincial public health. Sorry, I'm used to giving this in the States, even though I live in Hamilton. We take that, and that starts a process. So at each stage, it can be aggregated with other hospital systems, other care providers information, and start giving a map of where things are. Matter of fact, in the testing we have done, we've been working with a GIS provider to create a mapping of where things are, so that rather than having to go to the the actual reports and pull it up and start searching through this, hooking it up to a GIS system really has made a difference. We've ended up with really strong reporting capabilities of infection control, of immunization information. Pretty much anything that can be communicated through FHIR or through CSV can be aggregated into a measure report and pushed so that a responsible agency or organization can make decisions. And that's the big thing. Right now, most of this stuff is proprietary out there, especially when you get to secondary sources like bed management or central monitoring systems. They're all proprietary. By moving to FHIR, we can get this so that anybody can use this information, aggregate it, and report up as necessary. Okay. Now, this is the fun part. It's how to automate it, because really, it does no good if we just get all the information together and somebody has to then sit down and count it on the screen. So we've worked it out two ways. FHIR path, which if you're familiar with FHIR, you should be fairly familiar with FHIR path, although it's not always easy to read. But it's widely implemented if you're using the Happy Stack, if you're using many of the publicly available stacks. They've done FHIR path. Many of the EHRs have not, simply because it is much easier for them to use their in-house languages rather than implement an overall. And of course, it's a subset of clinical quality language, which was developed by HL7 and with others. But not too many people have CQL actually put into, but it's much easier to read. Not that FHIR path isn't the be-all and end-all. It's wonderful. I know I've had to work with it far too often. So let's look at FHIR path. This is where, if you're not technical, you may fall asleep. I'll wake you up with a loud scream as soon as we're done. What you want to do, because there's two ways things need to do. first is count something and then stratify it. And the important one is stratification needs to be done at many levels, and sometimes recursively, because you're going to sit there going, okay, I need to know how many men and women, I need to know how many men under, under 12, how many over 12, how many, and so on and so forth. So stratification becomes quite important. So for beds, you can do inpatient, non-ICU, inpatient, ICU, and everything else, because the rest aren't as important, especially in times of COVID, when ICU bed counts became vitally important, and we needed to work on it. So when you're putting this in FHIR, what you're seeing here is actually FHIR shorthand. Sorry, I was about to call it FISH, which is the short name. FHIR shorthand, because we're way too lazy to type out the long one, and it's much easier to read this way. So the expression itself, it's in text FHIR path, is the language. The expression itself says, look at the location and resolve it from the encounter resource. And we're going to assume that coding has been done properly and these beds have been marked out. So if the bed is, resolves to a non-ICU bed, great. If not, is it an inpatient CPU? And if not, of course, it's other. And using this method, we'll just go through it. So encounter, location, and under location, and then you ask it, okay, resolve what this means. So, and we're going to resolve it through running it through if structures. So if is the type member of and non-ICU, so that it uses a non-ICU code, and you have defined this already, which makes it a member of inpatient non-ICU. If it's not, we go through, we check it again. Is it one of the ICU locations that have been properly coded? If it is, obviously, it's an inpatient ICU, and we're done. Otherwise, we're just going to throw it in the other bucket. To count the beds, well, it comes out of the same place. You're still looking, sorry, this is kind of small. I'm going to zoom in a bit. I'm going to zoom in just a bit to make this a bit larger. And we'll just go 200% because I'm like that. There we go. Nobody likes an eye chart, especially when you're trying to read code. So total number of beds occupied. So we're looking at the beds that are currently in use in the most recent location. So when we've created this, we've of course added location data to it. So we're looking at this just for the location it's in. Obviously, when you get to the aggregation level, if you're a SANER intermediary, measure intermediary actor, you will want to adjust these because you're going to start looking at aggregation right across. So you want to find all the encounters, which has whatever you're looking for. So the subject has the condition of reason. So they're COVID patients. So with status, they're currently occupied, equal to their current in progress. So this is a current active occupation with today's date. And we make sure the date is within the reporting period we're interested in. So if it's the past 24 hours, if it's the past hour, if it's the past 7 days, that has been coded in as part of the measure. On the servers, we're going to just pull it from the base server. We're not going to start pulling from whichever, because right now we're looking at encounter resources, which should be pulled from the EHR. So we want to select the most recent encounter for each location. That assumes the encounters are returned in reverse chronological order. If it's not, well, then we need to adjust this, but most return in reverse chronological order, meaning the most recent location is reported first in every location. And you aggregate it. If the total from that location contains this location, then add it to the total, add this to the total. It's not always easy to read, but this is what we're working with. There are things such as Fluent Query, which you may want to look into. This can give you a lot better information when you're trying to pass on how your queries are being done. However, base FHIR path is what is going to be used in most FHIR servers. So, as I said, the aggregate returns a list of the counters and location resources representing the beds in use, and this allows us to do the additional stratification we're looking for by the encounter, by location, and start looking at this to aggregate up where we need to, or just give give the count for this location, put it in the measure report, and send it forward. I'm going to zoom out now because I don't want them all to look like this. Okay. I'm either boring you to tears because nobody's typed the question, but that's fine. Okay. Let's look at the pilot, because one of the things that we've been doing is trying to bring it to life. As I said, we only started this whole concept in February of last year. We brought together people right across, like I said, EPIC, SANER, Athena. My company was involved. We brought quite a number of players, including GIS providers, everybody out there to try to get things going, to create a FHIR IG that could really help bring the information where it's needed. So working with the Texas Health Services Authority, we're putting together a pilot. And here is all the lovely text that was given to me by the United States Office of the National Coordinator for Health Information Technology, also known as the ONC. I'm not going to read this because I don't want to. However, if you'd like, I can send you this slide. You can read it at your leisure. It all boils down to, we're working with the THSA under a grant from ONC to conduct a proof of concept pilot to demonstrate, well, near real-time automated exchange of what we're trying to do, hospital capacity and other supportive data through HL7 FHIR APIs. The rest of it is all very interesting. This is the second slide they gave me. THSA got all of it out of the ONC through HHS, and my company, Audacious Inquiry, is supporting as technical vendor. Now that I've read that, I can move on to the interesting stuff. Ha, ha, ha. Wait, no, they gave me another slide. I'm not going to read this one either. But we are coordinating with CDC and the U.S. Digital Services and local agencies in Texas and others. Okay, now that I've done that, and you're all very excited by the legalities of it, let's move on to how this information is going to flow. Currently, we're working with 2 local hospitals in Texas. We have a small, what's called a critical access hospital. It is a 24-bed small organization who has put together their willingness to do this. And then we're working with one of the largest teaching hospitals in Texas, Texas Parkland. And they are just upgrading themselves to FHIR. And that's one of the great things, is we are learning that FHIR is not as available as we'd hoped it was. And we're also learning that finding partners after your initial one has left is quite a pain. We're going to take that information, and there's 2 aspects of it. We're going to take all the bed information and what other things that they're currently reporting to public health in Texas and send it forward to the Texas Health Information Exchange. So THSA maintains one of the HIEs. There are actually 4, but THSA is the coordinating entity for all of them. We're going to take that and supplement the information from other organizations, because what we've realized is a lot of the information around isn't always the best, especially when we're getting to things like health equity information, race and ethnicity. Those kind of things aren't always available, and they're often very germane to treatment. So while it's good to know how many beds are available, being able to supplement it with additional data is a wonderful thing, especially when you're getting to immunizations, which, if you follow the news, Texas is not one of the great immunization states. So bringing that information, how to get things out there. So we take all the information from the bed management, from the EHR, from whatever supplemental systems we can get to. We send it into the regional HIE. Now, this doesn't need to be the regional HIE. The intermediary can be almost anyone. So if there is a local public health authority that needs to get this information, so around the county, around the city, around the Greater Toronto area, this can be, whoever needs to aggregate and use this data can get it. It doesn't need to go through an HIE. However, for the purposes of this pilot, that's what we're working with. From there, we're aggregating it, sending it up to the public health authority for their information. And they can merge that with the information they have from other sources, again, helping to guide information right across the region. And then ultimately sending it up to the federal authorities. So in the US, that's the CDC. They have shown great interest through the National Health Safety Authority, and National Health Safety, NHSN, can never remember what that stands for. Anyway, I only talk with them once a week. Isn't it great? To send it so they can start looking at things on a national basis, especially when you're starting to deal with sending out the information about national stockpiles. The U.S. maintains a national stockpile of intubators. They have national stockpiles of other support information. But one of the big problems was just finding out who needed it most, because the information was stale, was far behind, and not always correct, because if one person, that's all they're doing, and they miss a box, they miss a bed, they miss 10 beds because they were distracted in the middle. When we automate this, we get quality controls that we can't get from humans. And while humans are inherent to the system, because they're the ones that need to go into the stock rooms, to the to wherever, and do the hand counting, we need to make it so that that information is aggregated accurately under quality controls and passed up without loss as much as possible in automated systems. So what we end up with, and this is an example using Washington State, is that we have the medical inventory, we have clinical resources, we have the local and state government command centers all coordinating information, aggregating this information, and passing it up. This gives us a view, and you can do it through heat map, which we have done. Unfortunately, I don't have allowance to show you one of the heat maps. They're still under development by other organizations, so I wasn't able to get rights to one. But you can see not only where this information is coming from, but where the information is needed, and where the relevant information and supplies can be sent. That gets aggregated again right up through the state, merged with other states at the national, so you can national level. So in the U.S., FEMA and federal public health authorities can sit down and go, wait a minute, this state is having a real problem, and we can tell from our projections, because you have 15-day, many of the measures will ask 3-day and 15-day availability. We know that we have 3 days to get a dozen respirators down to the system, or a dozen ventilators. Sorry, I keep using those words interchangeably. It's a terrible habit. Or conversely, this state isn't having a problem right now. Let's see if they're willing to release some of the information, some of their resources to the national stage. And that really has made a big difference. So while we are looking at this on an international basis, we've talked with people all over trying to get FHIR and get the SANER FHIR IG. We did originally look at it doing it for the US, and then we realized this was far bigger. It's not just the US that's having this problem, and in a large extent it's not just for what we thought about, which was was for the novel epidemic, and that's where we ended up. So really that's the end of my presentation deck. I do want to get to questions. The biggest thing, I'm going to see if I can show you the FHIR IG, see if I can do this. I'm going to stop sharing for a second, and then I'm going to start again because I like doing that. There it is. Nope. There it is. Okay, so let's actually show you one of the profiles. If you have questions, type them in, interrupt me if you will, because this is the optional part of our system. What you have here is our profile on the actual measure resource. Now, in a lot of ways, we've had to do this, and I'm just going to switch over to what we call the differential version, which is just the changes we made. And as you can see, what we did is mandate a lot of this information be supported. So those big red S's mean must support. That means if the information is there, something must be done with it. You can't just throw it aside. And a lot of this information, because of the urgency it's created, we've done this to make it so that these things can be updated and marked whether they're active or retired. So when you can actually send down saying, hey, this is what we asked for, send down another measure saying, we retired that one, here's a new active version. allowing them to be updated and as needed several times a day if necessary, which, if you were working with some of the public health measures during early stages of COVID, they were being updated sometimes 2 and 3 times a day, which is why so many of the reports were badly stale, because suddenly knowing how many of this type of bed was no longer important. We only cared about, ICU beds, or suddenly we're no longer caring about just ICU beds. We need to know more. So everything had to be taken care of, which is why we added forcing most of these things to be must support. So who's getting it from, where it's coming from. And of course, we also created a public health measure library so that we could do it. So many of these things were sliced, and hopefully by slicing, that means we figured out there were specific sections of it that needed to be done. So we could do it by point in time, cumulative, and then we get down to the simple things, right? What the population criteria. And by population, we don't necessarily mean humans, although we can put workforce information in this. But what kind of thing? So is this numerator, is it extension, denominator, that kind of thing? We forced that the population had to be there so that you could create from this the measure report. Each one had to have a numerator and denominator, obviously, because if you're trying to figure out what, how many are left, needing to know whether this is the total number or the current number available is vitally important. And then we had the stratifier. So we had, and this is changing because originally we only talked about having one level of stratification. Doing this in Texas and doing this in some of the others, we've realized that was horrible assumption to make. And we are removing that requirement that stratifiers only be one level deep. We will change this, and there will be what we call an STU update, so non-breaking change publication that allows things to be updated, that removes this restriction. And then at the bottom, supplemental data. One of the things that came out is that in many cases, although it may not be important at the state level or at or at the HIE level, but when you're counting immunizations, if you're counting records, many times the organization needs to know not only the count, but it needs to know who. So the Centers for Disease Control, if they're doing immunizations, need to know everybody that's been immunized. So creating the supplemental data means we can throw the entire list of who's on it. It could be de-identified as appropriate, or if all the things are in place, send the real data. This really gives how it can be done. And each of these, of course, are done through measure criteria, which is just a straight expression. Now, what we've done is, we've set this to be FHIR path, but the description needs to be there, and of course, the expression itself. It's possible to do recursive measure criteria, but we've set it so that how to can be computed, usually with FHIR, as said, with FHIR path or CQL, depending on what your preference is. If you have some other way to do it, we will allow that as well. And if you look at the FHIR IG itself, we've done as much as we can to make it as available as possible to people who need to do this. So we have guidance on creating measures, how to do it with patients, hospital-acquired infections, so on and so forth. All of this has been here to roll it out as simple as possible. We have test plans, we have information on the technology environment, again, how to exchange it with CSV files, aggregation, computation of the measures. We made this as possible and as open as possible so it was available to people. And of course, because we based this in FHIR, but around the basic concept of the IHE profile, the architecture, security considerations, all the various different types are there, as well as a list of all the profiles and extensions, and of course, lots of introductory text because everybody likes a good read. And with that, I'm going to shut up because I've been talking for a while and really would like it if other people ask me questions, or maybe I've just told you everything you ever wanted to know about situational awareness on FHIR, and you're all going to go home and just read up and never bother to talk to anyone ever again. Take it away, Fergus.
Well, Dave, thank you very much for the for that talk there. I mean, on a very personal level, I thought that was fantastic to see the real world application of some of the things that you were talking about, because it's very easy just to kind of get trapped into the situation where you're sitting behind a desk doing the developing and not really sometimes seeing what the real world implications thereof are. So I do have a few questions for you. So what other implementations of SANER are you aware of?
Right now, as I said, we have been working with both Epic and SANER. They are building into their stack the SANER FHIR IG. So we're starting to see it worldwide, which is lovely. It's still in the development stack, so those of you working with the latest of the R4 FHIR IG through Epic or SANER will not see this, because we just published it a month ago, and so, it's a little bit of a lag. However, we've been working with Texas, as I said. However, we've been approached by Arizona and Washington State, which is why I used them on the slide. They are putting this information together. As well, we've been approached in Australia and in 2 countries in Europe. They are putting this together. We're not involved, my company is not involved in putting it together. We have happily released this without making it proprietary, because that's the way it's done in FHIR. But we are looking forward to seeing it spin up, so that when the next thing happens, and of course there will be a next, that this information is available, and we're not sitting in a panic going, what do we do now? And I must admit, it gives me a good feeling, because I've been involved in creating a way to help people get better, which is why I got into healthcare IT.
Oh, fantastic. I think you touched on this point earlier on, but I think maybe we could just take a bit of a deeper dive into it. Also, what have you learned through testing about your initial design choices?
Well, yeah, I touched on this earlier. Originally, we were naively thinking, we'll just create a questionnaire and we'll use the questionnaire resource, and that's fine. And then early on, we've been through 5 FHIR Connectathons with this, because this is important. We want to make sure everybody has been tested. So that was thrown away. And after the first one, we threw it all away. We started on the measure report, partially because the questionnaire was very limited in how you could put the data together, but also because it didn't allow itself to be aggregated easily, right? Especially when you're starting to look at supplemental data, when you want to put how many specifically, all the patient records on it. So we threw that away. Also, we've learned that much of the information that we're creating needs to be done not only on the aggregate level. So if you look at the questionnaire I put up earlier, most of it just said, do you have a 3-day amount? Do you have a 10-day amount? Do you have a 15-day amount? Or, do you have enough for 3 days? That's useless information once you get on the ground, because you may have 10 patients right now, you're going through, 20 of this every day, and then suddenly, 10 ambulances show up, you have 20 patients, and your 3-day supply just dropped to 1 day. So it really needs to know how this information could be done, and not aggregated, but literally live, as near real time as possible. So that's why we moved again to the numerator denominator concept, where you have 5,000 masks, but you're going through 1,000 a day right now. However, tomorrow you may go through 1,500, and so it can be updated live, number of patients, number that are being used on a regular basis, really getting it. And of course, as I said, we were naive enough to think that one level of stratification. So we'd only care of male, gender. Oh no, gender under, age under gender is just as important. We need 4 buckets. That was the one thing that came out really at the last Connectathon we had in September, was when we realized, holy crow, we've made a horrible, horrible mistake, and learned from it. And we'll be putting out changes based on that, which is why it's vitally important to run your FHIR IGs through Connectathons. And I'm not just saying that because I'm part of the HL7 TSC.
Oh, fantastic. Sounds like some good advice there. So who have you worked in creating SANER?
Well, as I said, Epic and Cerner were right off the bat. They came in. Some of their their people who are helping design FHIR worked with us, and Cerner has been an ongoing partner. In fact, they have made their system available as a data source right through all of the connectathons. In addition, we've been working with Geographic Information Systems. There we go. GIS. Sorry, I've been talking a lot today. GIS systems to try to figure out how to make this best available. Because as I said, having a screen with 20 numbers on it isn't very helpful when you're trying to quickly make a decision. So we've been working with those suppliers to create tables, things like comorbidities. So when we're bringing up the information, CDC needs to know where are the comorbidities, for COVID. Are they strong? Are there this many in this area? Is this an area we need to send specific support to? As well, just being able to say, hey, we've got 50 beds in downtown Calgary that can be used when we've only got 8 beds left in Edmonton. That's a big deal. So being able to do that on a geographic level, or let's look at Medicine Hat. It has 1 bed left. Let's get some of their patients transferred. That's the kind of thing we've been learning, and really it has grown it a lot. Just trying to work out exactly how to bring the information and how to refine it, right? How to, we brought in CQL only because somebody said, wait a minute, I may need to do more in-depth analysis than FHIR allows me to do. All right, clinical quality language will help you do that if you can, if your system supports it. All of these things have really helped us grow over the past year. We've had a lot of companies come in and move out. And, we've worked with Microsoft, we've worked with, as I said, Epic and Cerner, we've worked with Athena Health. All of these organizations have helped and brought this faster than we ever dreamed possible. We set the record for getting a project proposal through HL7. Simply because everybody made it possible, right? In 2 weeks, which normally takes 3 months, we got a project from, hey, this is a great idea, to, okay, you've got everything you need, start. And we did. So, I have to thank HL7 itself for just making sure that everything was done and everything was made possible as quickly as we could do it.
Okay. Well, Dave, I think that's the end of the questions at the moment. We haven't got any others in the chats come through. I do have one service announcement to make here. It just comes from, I'm going to read this from my mobile phone. It's come through from Andrew. So apparently we're experiencing an error on feed loop at the moment. It's not FHIR, this is feed loop. But it's just the request is, hi everyone, quick note that our virtual event portal is having some issues. If you can stay in here until the session is over, that should prevent you experiencing the error. So if you just stay on, that would be fantastic. However, as it is, I think we will be wrapping this up now.
And Fergus and I will do a duet until it's over to keep you entertained for the next 6 or 5 minutes.
Yeah, maybe you can talk us through how you invented peanut butter and jam sandwich. If anyone joined late, that will make no sense whatsoever.
Yes, and even for the people who joined on time, it still makes no sense.
Okay then. I think Laura, if you want to kind of draw us to a close, just let everyone know there is a networking break. I think now and then the next session will be the ONC FHIR at Scale Task Force with Patrick Murta. So I hope you continue to enjoy today, and thank you very much for your participation in today's session. And once again, Dave, thank you very much for your time, and talking through a SANER approach has been a fascinating hour of our time.
Great, thank you, sir.
Okay, thank you.